interrupt me and lead the discussion.
That's fine. We have a lot of people to comment on the case for sure.
Perfect. I'll share my screen. Can you see it?
Oh, yeah. Yeah.
Okay, so today I'll be presenting a penetrating neck trauma with major venous injury case. And my main learning objective is to discuss operative strategies for proximal vascular control on cervical thoracic junction injuries, and also to assess risk and benefit of venous repair versus ligation in jugular and brachiocephalic injuries. Oops, one second. So to introduce myself, penetrating neck trauma in zone 1 is associated with a high mortality due to difficult access to the great vessels at the thoracic inlet, and this is mainly because of the protection of the manubrium, and we should be prepared to perform a sternotomy when cervicotomy alone is not able to comprehend all the vascular injuries. And we also want to discuss whether jugular ligation, besides being a safe and common option, is the best choice to the patient. And we would like to present the opportunity of doing the vascular repair, mainly when we have a bilateral injury or when we're talking about smaller injuries. But it also carries an inherent risk of thrombosis, and sometimes we cannot prevent it even with anticoagulation. So I'm presenting a case of a 28-year-old male that presented to the emergency department brought by rescue services. He presented to the emergency department only 15 minutes after the accident, and he had a relevant past medical history of a prior ablation for Wolff-Parkinson-White syndrome. And he presented with a mechanism of a stab wound to anterior neck on zone 1. He had a single sharp wound approximately 4 centimeters over the sternal notch. He had oozy bleeding, local subcutaneous emphysema, and no air leak. He was hemodynamically stable with a BP of 113/71. He had 97 of heart rate. He was conscious. He was sweating profusely. He was dysphonic and agitated, and the pre-hospital did no treatment. So on a primary survey, he had an airway at risk with dysphonia, with local subcutaneous emphysema, and we suspected immediately of an airway injury. He had a respiratory rate of 24. His sats were on 100%. He had diffusing bleeding with no hemodynamic stability. He was conscious, agitated, and this was his only lesion. So we decided to proceed with immediate orotracheal intubation due to the suspicion of airway injury that we accounted on the dysphonia and cervical emphysema. He had a hoarse and altered voice, and we also thought about this lesion being on zone 1. We feared that he had a progressive rapidly airway compromise that we could not assess if he wasn't intubated. We also did a arterial blood gas on him, which was interpreted as a compensated metabolic acidosis with hyperlactemia. And we assumed this was an early evidence of hyperperfusion. He had a lactate of 44 with a pH of 7.33. Now it's the first point for discussion. We wanted to talk about the difference between the zone-based approach in which the anatomical disposition of the neck with the trauma injury is the standard for defining which approach we're taking, but in our service, we're shifting towards the no zone approach, in which we find ourselves looking more into hard signs versus soft signs of trauma to decide whether this patient goes immediately to the OR or whether the patient goes to a selective workup. In this case, was a CT angiography. So our patient presented with dysphonia and also a subcutaneous emphysema, and accounting him for only soft signs. He had no refractory shock, he had no expanding hematoma, no active sternal bleeding, no clear airway compromise, and so we consider he was stable enough to go in for a CT. I don't know if you'd like to share anything, Dr. Carlos.
So yeah, I wanna stop you for a second because I wanna ask the panelists about the management so far and the next options. And as always, we have very, very uh, distinct group of people here to talk about the case. So why don't we start with Dr. Untracht? And I want to ask Dr. Untracht about the management of the airway. So if I understood correctly from your presentation, Eduarda, it's so the patient, there was no signs of obstruction. The patient was communicating, but you did find some subcutaneous emphysema and some dysphonia, right? So I
Yes.
wanted to ask Dr. Untracht, what would be the rationale to either, I mean, at first, would you do the intubation as they did, or would you defer the intubation for another moment? And by deciding which way you go, what's the rationale behind your option?
Yeah, I agree with exactly what Dr. Eduarda did. I would have done the same thing in this case. There's a patient that awake, talking to you, stab wound with dysphonia and emphysema. I think it was a perfectly good way, smart way to manage the airway. And it's if you had put it off and there was sudden swelling, or if you decided not to operate immediately but to do further studies, you don't want to have to worry about the airway. So I agree fully with that. And Dr. Eduardo gave away the whole management plan, so we have very little to discuss. I think that it was perfect what she did, and for the reasons shown on the slide, I think it's perfectly fine to go to CT, do a CT angio, and look at the venous phase and see exactly what you're dealing with, and then you can plan any operation if one is indicated with precision.
All right, perfect. Let me ask Dr. Frisby. Dr. Frisby, what would be the options here? Let's assume that this patient came to the ED, dysphonia. He has some bleeding on this stab wound over the sternal notch. And what are the options that one might use to try to get some hemostasis while in the ED? Let's assume this might be just a simple or small oozing, as she described, but also in such cases, you can either have a venous bleeding, ongoing venous bleeding that did not stop, or either arterial bleeding. So, what are the options to try to contain this or to stop the bleeding at least temporarily in order to get this patient elsewhere?
Well, one of the things you can think about doing is take the balloon down from the ET tube, push the ET tube down about a centimeter, and blow the balloon back up. See if we're dealing with um, see if we're dealing with a venous or an arterial matter. But I would never send anybody to the CT in this condition without intubating them first. There have been too many episodes of uh, real problems during that period. But that's one thing I might do. The second thing I could do is look at the stab wound itself, and I might take a small Foley catheter into the wound itself and blow the balloon up there. But those are the two things I might do.
All right, perfect. And let's see, Doctor. Let me see who else is here with us. Hey, Dr. Hochman. So nice that you are here as well. Thank you very much for participating. So, in this situation that you have this kind of patient, we are discussing now, since let's assume that the patient was intubated, bleeding is controlled, and now we have to decide if this patient should go to the operating room directly, or if he should go to the CT scanner, for example, or even if you want to get different studies. So, what would be your approach in this situation, and how do you decide whether to take these patients to the CT scanner before, or directly to the operating room, maybe with some basic other studies?
Okay, let me backtrack a little bit. Um, you have two things here. that they can be combined. One is zone one injury that you're always worried about vascular injury in that area. And for that, if you have the chance, getting images before is the way to go. The second is an aerodigestive injury because this guy has problems with phonation. So I will suspect, based on the location, that the trachea's injury may be the trachea and the esophagus. So on those, the patient needs to go promptly to the operating room. So you have a conflict there between doing the imaging studies that you would like to get and the emergency of the airway. If the patient is hemodynamically unstable and bleeding, obviously that patient goes straight to the operating room, but this is not the case. So in patients like this, I put a word of cautions with the intubation because I have had patients where the trachea was completely disrupted. Patients where the esophagus is also involved and the ET tube can end up in the esophagus. So if I were to intubate this patient in the emergency room, I will do it fiber optically. I will get anesthesia and do the intubation fiber optically, with the caveat that you need to do a rapid sequence. And sometimes those patients, when you do a rapid sequence, they crash. I have had patients like this that I brought to the operating room and intubated in the operating room because I was going to operate anyway. And the operating room is a much more controlled environment where to intubate the patients. So if I can intubate this patient fibro-optically, and if the patient is hemodynamically stable, yes, I would like to go to a CT scan to get imaging because it will help me to plan the approach. Granted that in most of the cases, this would be a median sternotomy. So that would be my approach. And the other thing I will do in this patient also, the part of the ABC, is you have air leaking there, so it's most likely from the trachea, but it could be from the lung. So I would get a chest X-ray in the trauma bay that might give me some additional information about where to proceed. So that would be my approach. Thank you.
That's great. Thank you very much. So we have also Dr. Veron here, and one of his specialties is exactly the airway and these trauma patients. Dr. Veron, any specific comments about the airway for these
Well,
patients? Anything different?
first, a decision has to be made if the patient is going to go for additional studies or directly into the OR. The patient has some, obviously, if there's subacute emphysema, there's an airway injury somewhere. Otherwise, there would be no subacute emphysema. And if he has dysphonia, that's a very specific sign, actually, of airway injury. So if the patient is going to go straight to the OR, I think the intubation should be done in the OR. If there's any question and you need additional studies and the patient is going to go to CT scan, then the airway should be secured. The strong recommendation, though, is that when you intubate these patients with penetrating neck injuries, the question is not, can I intubate? Will I be able to see the vocal cords? The question is, what's below the vocal cords? If I just use a video laryngoscope, where's the tube going? Because the tube can go through those vocal cords and go back into the esophagus from there. So the safer approach to do this is to do this with, we don't have fiber optics, by the way, anymore. They don't exist for the past 15 years. They're all videoscopes. So now we call it flexible bronchoscopes. So there's two options. One, which is in the minority of patients, those patients who are scared, but are following commands. They're not fighting. They're not punching you. They don't think you're the one that stabbed them in the neck. In those patients, you can do this awake with a good topical anesthetic, and will give you enough time to do this with a bronchoscope. So you can see where the scope is going. You can position the bronchoscope just above the carina and thread the tube over it. If the patient is like the majority of patients who are agitated and all that, you just can't do that. So what I recommend in those cases is what we call a rapid sequence bronchoscopic intubation. Now, every hospital has a bronchoscope. So what you do is you put the bronchoscope, you put the tube on the bronchoscope, you preloaded it, and you do rapid sequence with the scope. So as the scope is going through the airway, you're just really looking for blood below the vocal cords. And the goal is to put that bronchoscope just above the carina and then to thread the tube over it. It's so everybody's looking at the video and you can see right there, is there an airway injury? No, as you're going in. Secure the tube just above the vocal cords, and then you can take a break and you can decide what you're going to do with the patient after that. Thank you.
All right, that's great. All right. So I'm gonna play some polls so everyone can participate as well here during the meeting. And I'm just gonna post another one that is we are already discussing a little bit, which is what to do with this patient once this is going to move forward. So I thank you very much for all your comments. I think we can move on with your presentation, Dr. Eduardo.
Perfect. So going on, we decided to take the patient for the CT angiography. And what we found, we were able to do this with a 30-minute door to CT time. And we did a CT of the head, neck, chest with IV contrast. And the main findings we had were cervical subcutaneous emphysema, pneumomediastinum, a small left hydropneumothorax, and we also find a loss of definition of the left internal jugular vein at its confluence with the brachiocephalic vein, which we consider was suggestive of venous vascular injury. And here on the left, we have a left pneumothorax, and on the right, we have the pneumomediastinum. One second. And these were the main findings on the CT. And based on the CT, we decided to take the patient to the OR. I don't know if you'd like to make any comment here, Dr. Carlos. Just to remark, the patient remained stable during all the CT and the transport to the OR.
Yeah, I want to ask you, I want to ask the panelists something. So, traditionally, basically all hemothorax were supposed to get a chest tube over the ears, right? But most recently, we've been seeing some publications and some literature about trying to selectively place these chest tubes in patients with a certain amount of hemothorax. Most of these studies were talking about a threshold of 300 cc's. And so either placing the chest tube in a patient with over 300 cc's or and in a patient without or just less than 300, you would just be safely observed. I want to ask all the panelists about their own practice, how they're doing this in terms of are you doing selective chest tube drainages for hemothorax, or are you doing basically overall chest tube drainages? And also, just on your answers, please add if you are doing thoracic lavage nowadays, or you're not doing any thoracic lavage. Dr. Untracht.
Yeah, so if it's a minimal hemothorax, I would leave it alone and watch it. And for this one, on these two images, I would put a chest tube forward. That's more than 300 cc's. It's going up to the apex, and I would drain it. I generally don't do lavage as long as the blood is completely drained. If I get a complete clearance of the pleural space, I don't rinse it out.
All right, Dr. Hoffman.
A few things with this that you need to be mindful with this particular patient. If you're suspecting an injury in the confluence of the jugular vein, the left jugular vein with the where it becomes the brachiocephalic vein, you need to make sure that all your lines are on the right arm. So that would be one thing. That is because putting a chest tube in this situation, you decrease the pressure inside the chest and you can bleed more. So I will delay the placement of the chest tube for now. I will continue resuscitation because the other thing that can happen on this patient, he has an air leak somewhere, and you have a system which is low pressure system, the venous system. So with the positive pressure ventilation, if you don't have the veins well filled, the patient can get air embolism. So those are the things. So let me recap. I will resuscitate this patient aggressively through the right arm, trying to have the central venous pressure high, even though it can cause more bleed. I will not put the chest tube there because it will accelerate the bleed, and because I will worry about the possibility of developing air embolism, and I will go to the OR. And after that, I will deal with the chest if I have to deal with the chest. And we are moving towards doing a lavage now that we put the chest tube with hemothorax, because that has been shown to decrease the incidence of retained hemothorax. But those are the things I will do a little bit different.
All right, perfect. Doctor, Doctor, is is Dr. Frisby there? Oh yeah, Dr. Frisby, are you there yet?
Oh yeah.
So what's your thought on that?
I think Hoyman's right. I think that you know, it doesn't take very long for that hemothorax to congeal and become jelly. I would probably put the tube when I was sure of that I wouldn't get an air embolism. I'd put the tube and I'd wash that chest out before that blood turns to jelly and you can't get it out. So I agree with Dr. Hoyman. Thank you.
Perfect. Dr. Kasim, any thoughts on that?
Good morning. So we've been doing chest tube for hemothorax for centuries or millennia or since surgery was invented, I think. And suddenly we want to do something different. You know, there's an old saying, when it is not broken, don't try to fix it. I think I would continue with the drainage of the pleural cavity for a very simple reason, like Professor Frisbee just told us. You don't want to leave a caked up blood clot in the chest, then you have to go back and do thoracotomy and decodification and leave residual material in the chest, which may get infected, and then you are in duck soup. I think the simplest thing would be don't play with something that has been working for centuries. Put a chest tube, drain it, and of course, lately they have been doing lavage. If your hospital is equipped to do that, I think it is a good idea to lavage it. But if it is not equipped to do that, you need two nurses to do lavage, one to watch it and the other one to adjust the fluid and all that. It's not a very simple material. I mean, method. There is labor involved, and be cognizant of all those facts. I think drainage, lavage is a good idea, but selective thing is a bad idea. You don't know what amount of blood is in the cavity. You can guess. Guessing is not a good thing in surgery. Thank you.
All right, perfect. Dr. Eduardo, I think you can move on with your presentation.
Okay. So after the CT, we decided to take our patient to a left exploratory cervicotomy. And the first thing we found when it did it, we found an active bleeding from the distal internal jugular vein. And this was the point where we decided to extend the access and do a median sternotomy for proximal vascular control, because we weren't able to find the limits for this bleeding and also to see extensively the lesion. And when we did the median sternotomy, what we found was a penetrating injury on the brachiocephalic vein extending to the left internal jugular vein. And this is the point where we opted to do a primary venous repair with fluoroproline and a continuous suture. The bleeding stopped. We were able to have a clean field after the suture. And then we saw a left pleural violation from the from the point of view of the sternotomy. And then this were the point where we decided to do a video-assisted thoracoscopy, in which we were able to do the pleural repair. We put a chest tube, and when we did the thoracoscopy, we found a hemothorax, approximately 500 milliliters, and a great presence of clots. We did a lavage, we did suction, and then we kept the chest tube draining. And in order to assess the risk of postoperative cervical collection and infection, we decided to left a Penrose drain on the cervicotomy. Now I'll present the video of the surgery with the highlights that I presented. So this is when we did only the left cervicotomy. We find that active bleeding, and we weren't able to identify the structures or to obtain the fill necessary to do the ligation or the venous repair. This is the point where we extended the access with sternotomy. And this is the full field we had to work. On yellow, we can see the left internal jugular vein. On marked on red, it's the left common carotid artery. And on right, we have the brachiocephalic artery. And that's the tear. So now we shift on the video-assisted thoracoscopy. This is the left subclavian artery. And now this is a finger placed from the open axis going to the pleural cavity, chest cavity. This is the final aspect of the incision and the drain place, the Penrose drain. The patient remained hemodynamically stable during the entire procedure, and he went out with no use of vasopressors. And the timeline of care of this patient, he suffered the trauma at 8:15 p.m. He arrived to our service at 8:30. He underwent the CT scan at 8:50. 9:20, he was already on the OR with the procedure after the anesthesia starting at 9:35. And the surgery ended at midnight in 55 minutes and with a total time of trauma care of 4 hours and 25 minutes. During the surgery, he received 4,000 milliliters of crystalloid, 1 unit of packed red blood cells, 2 units of fresh frozen plasma, and we also had cell saver available, and we were able to give it back 700 milliliters to the patient. Do you want to make any comment, Dr. Carlos?
Yeah, I was gonna stop you right there. So a couple of things that I want to ask. First of all, I want to ask, I don't know if Dr. Varon is still there, because I want to ask Dr. Varon about this intraoperative resuscitation strategy. So we hear a lot of literature, and we read a lot of articles talking about the transfusion, whole blood, and so on. And we always see the reports, the anesthesia reports, and they have in the reports a lot of crystalloids, which for the surgeons, when we look at the reports, we feel that this is too much fluid. And it's I've already seen Dr. Varon talking about the crystalloid situation for the anesthesia. I wanted him to share his view about this resuscitation strategies intraoperatively in these patients.
Well, there's no question that I would say over the last 10 years, damage control resuscitation, the way we do things have changed, and a lot of this came from the military. And now instead of crystalloids, we use the real colloid. The only colloid that will not leak out is packed cells. So that's what we use instead of crystalloids. We try to minimize the crystalloids. Unfortunately, sometimes we exaggerate, but you still need to give some crystalloids. When you're doing a Whipple operation, you still have significant losses for that. But now we try to minimize it. In the trauma case, obviously we're using 1-to-1. You can even use 1-to-2, but we have replaced, and we use preferably whole blood or packed cells and fresh frozen plasma instead of crystalloids. That doesn't mean you're going to give zero crystalloids. Our surgeons here at the trauma center want to give zero crystalloids, and I have to explain that you need crystalloids to dilute the antibiotics, and sometimes the red cells, you have to give a little bit of crystalloids, so they're still used. But in this case, for example, the patient retrospectively probably should have received more packed cells and fresh frozen plasma instead of a large number of crystalloids. The concern about crystalloids is that in many of these patients, eventually you can have compartment syndrome and other complications, extended stays in the hospital sometimes because of that. Now, you have to remember, I'm from an era that we gave crystalloids like the Michelin Man, correct? I remember as a fellow giving 40, I'm not saying 40 liters of crystalloids over 24 hours. And my attending says, we need to maintain kidney output. If that bothers you, you just cover the patient with a sheet. That's just cosmetic. We're not in that era anymore. So again, we have replaced now, we use packed cells, fresh frozen plasma. Whole blood is much easier for those that have it, because then you don't have to be, coordinating the use of packed cells and fresh frozen plasma. But if you don't have it, we still use 1-to-1, in some places 1-to-2 ratio, and try to minimize the crystalloids.
All right, perfect. Let me ask Dr. Hochman about the surgical approach in this case. So, if I understood correctly from Dr. Eduardo, they started with the cervicotomy. They weren't able to get a good exposure, and then they did the midline, the sternotomy. So, Dr. Hochman, based on the CT scan and the possible trajectory of the stab wound, would you also start with a cervicotomy and then go for a sternotomy? Would you do a sternotomy right away, or would you do a different approach, maybe a cervicotomy and then trying to get access to the subclavian using a more lateral approach? What would you do?
I have just one question. I didn't understand. The incision was anterior to the sternocleidomastoid muscle or just above the clavicle? That's the part I didn't understand.
I think it was an oblique anterior to the sternocleidomastoid. Yeah.
Okay.
Yeah, it was anterior, obliquely anterior to the sternocleido.
So, if a basic principle of vascular injuries is you need to get proximal and distal control. So you can probably get distal control, but not proximal through. And you can try. I would have probably had to really review the CT scan and see sometimes the confluence between the vein and the two veins is high, and you can try to approach through the neck. But I would probably prep everything for the median sternotomy, because you need to get proximal and distal control. The problem in that area is that the phrenic nerve is very close to the jugular vein in front of the anterior scalenus muscle. So if you struggle to get control, you have a chance of injury the phrenic nerve. I will err on the side of having a big incision rather than trying to work through a small incision to get vascular control in a case like this. There are other cases that if you know it's a venous injury, you can be a little bit more brave and try to tackle directly and try to find get the proximal control by going through the hematoma. But in a case like this, when I have the chance of having an injury to the phrenic nerve, which is very close, I would probably do a median sternotomy early rather than late. One of the questions was asking about partial sternotomy. I know it can be done, but I personally in trauma, I don't like to do it. Maybe I am too old-fashioned, but it's if you're doing an elective case, it's okay. But in trauma, I have been more than once surprised by the findings. So I don't want to be surprised and doing partial sternotomy and suddenly realize that I don't have good access and I need to extend the sternotomy. So I definitely would not do a trapdoor incision, which is an incision above the clavicle, partial sternotomy and second intercostal space. It sounds good in practice. It's a very morbid incision. Yeah, so that would be my approach.
Right, that's great. Let me ask Dr.
I
Kasim.
can add, I couldn't agree more with what Dr. Baron just said too about the crystalloids. You need to give crystalloids if the patient is open because water evaporates, but this patient lost blood, need to be uh, need to receive blood. That's the bottom line.
Yeah. So, Dr. Kasim, let me ask you also about the management. So now I wanted to ask you about the venous management, so the venous injury. Um, and there needs to be a decision intraoperatively if we're gonna ligate the vessel, if we're gonna do a primary repair, and if we're gonna do anything else. So, assuming that this patient was stable, and considering that this is a subclavian injury, so I think most of us would try to do a primary repair. But I wanted to ask you, sir, about some technical tips to make sure that your suture is not going to be too narrow, and also what kind of sutures would you use? Would you do how would you approach this vessel injury?
Well, this particular case, if I were the surgeon and I saw this case in the trauma bay, I would start planning right from the beginning my plan A and plan B. A good surgeon always has a backup plan, and that is plan B. Second thing, in vascular surgery, like Dr. Hodgman says, you need to get control of proximal and distal. In a case like this, the proximal is the most important part. The distal is not that important. So, having determined that, the choice of incision becomes quite clear to me. The first thing I would do a median sternotomy. And if I had problem with the distal, I would just extend it up into the neck, whether it is transverse or oblique, whatever it is. Terminology wise, you're looking at the innominate vein, which is the confluence of jugular and the subclavian. And I believe this injury is most likely the innominate vein we're talking about. It is a fairly large size vein and it can be easily repaired unless it is completely transected. If it is completely transected and you're missing a part of the vein, the smartest thing would be to go ahead and ligate it with impunity and that the patient will survive. The thing you don't want to do in the operating room, allow the patient to bleed because they can lose blood very quickly and they may bleed out and you may not have caught up with it. So either you do a lateral repair, in other words, if it is an incision going on top, you put side sutures on each corners and you repair it that way so the lumen doesn't get narrowed. And that's what I would do. The second thing is regarding fluid management. There is a wonderful picture by John Holcomb in the textbooks nowadays. What happens to your gut and also your lung when you give too much crystalloid fluid? And I keep that fluid, I keep that picture in my mind all the time when I resuscitate the patient with crystalloid fluid. You can go ahead and give a 500 cc of crystalloid fluid. It is not going to do any harm. But if you are going to talk about in liters, it does certainly will harm patient. That is when you recall John Holcomb's picture and say, don't do it. Thank you.
Nice. Thanks a lot, Dr. Kasim. Dr. Eduarda, let me just ask you a question before we move on. Why did you guys decide to put to place the drain there? Was it what was the issue? Was there a esophageal injury or something that you were afraid of having a fistula or something?
Dr. Carlos, we didn't think about a fistula, but the main concern was infection, cervical infection, because we didn't know where the knife came from, and it was thought to be a dirty wound. So the surgeons opted to place the drain.
I see. All right. Let's move on and we can.
Dr. Carlos,
Yeah,
can I just respond to that?
of course.
Don't forget, when you put a Penrose drain, it is a two-way track. You can drain things out. You can also drain things in. So be careful when you rely on your Penrose thing that you are doing a good job. But more than not, that you may be introducing foreign bugs into the area where you have just finished operating and leaving some blood behind, and that becomes a nidus for infection.
Yeah.
Draining anywhere except you have a established abscess for prophylactic reason is not a good idea.
Yeah. Dr. Kasim, since you talked about it, you wouldn't leave any drains, right?
No, sir, I would not leave any drain in that area.
All right. Perfect. All right. All right, Dr. Eduardo, you can move forward.
Okay, so this was the postoperative radiographs from first postoperative day to third postoperative day. And this was when we opened the incision on postoperative day 2, he had a clean wound. And this was the aspect of the Penrose drain. So the postoperative course of the patient on day 1, he was on ICU. He didn't receive any vasopressors. He was awake. He was breathing with no oxygen support. He received diet with a good acceptance, and he had a 200 milliliters chest put out to a serous sanguinolent. On second day, he was discharged from the ICU, and we started prophylactic anticoagulation. He had a chest tube output of 100 milliliters. On third day, he was already a ward patient with a chest tube output decreasing. And then on fourth postoperative day, the patient complained of a leper upper limb edema and a painful leper upper limb edema. And then on fifth day, we started him on full anticoagulation, and due to the worsening of this edema. And on sixth postoperative day, we perform a Doppler ultrasound of the left upper limb and also the neck. And we found a deep vein thrombosis on the subclavian, axillary, brachial, left subclavian, and left internal jugular vein associated with a thrombophlebitis of the distal aspect of the left hand, which was one of our concerns when we first decided to do the venous repair instead of the ligation. And hopefully, the patient had an improvement of left upper limb edema 2 days after the beginning of the full anticoagulation. And he also maintained a chest tube output reducing besides the starting of this anticoagulation. So on 8th postoperative day, the patient had a reduced drainage from his chest tube. He had improvement of symptoms. He had no respiratory discomfort. He had a good acceptance of oral intake, and we discharged him on full anticoagulation with rivaroxaban. So This is a summary of the patient evolution, and he didn't have any relevant cervical drainage on the Penrose, which only supports what Dr. Kasim said. We probably just left a door for bugs to get into his chest, and we removed it on the 7th postoperative day, and his chest tube have a stable and reducing drainage besides the introduction of full anticoagulation. He had a very brief stay in the ICU, and this is the outpatient follow-up. He returned to our general surgery and also to our trauma service clinic with a good exit wound. It was healing. He only had mild pain at the thoracic incision. He had no respiratory complaints, and he was taking rivaroxaban daily without any complications. I don't know if you want to stop to discuss anything, that Dr.
Yeah.
Carlos.
Yes, please. So there's a question on the chat from Dr. Gamara asking if the patient ever got endoscopy or a bronchoscopy to evaluate for aerodigestive injuries before, I mean, either before or after the surgery. I didn't see anything in the presentation. I don't think so, right?
He didn't.
All right, perfect.
Not before, not after surgery.
Yeah. All right. Well, that's a great case. I want to go for a final round with the panelists. Any final comments and maybe any additional comments on ways that we could try to prevent this thrombosis from happening? Was there anything in particular in the case that we might have done differently? For example, starting the DVT prophylaxis before the second day, or even using heparin intra-op. I don't know if it was used or not, but let's see if the panelists have any thoughts on that. Dr. Untracht.
Yeah, I don't, as far as I know, there are no studies comparing the various options. The only other thing that you could have done was maybe repair the vein with a patch, a venous patch. But, I think the incidence of thrombosis is rather high. I presented a case where we did a lateral repair in the internal jugular thrombosed, but the subclavian vein on that side did not, and the injury was right at the junction of the two. So I think it depends on the amount of flow. But regardless, it's ligation is a reasonable option for those injuries, and you may have early swelling, but it almost always resolves with time with collateral flow and recanalization. So no worries. And I think in this case, the patient was stable the whole time, so it's reasonable to go ahead and repair. If there are multiple injuries, I would have ligated, and you probably would have also. About the crystalloid, I think the patient just reflexly got too much crystalloid with that, because he wasn't hypotensive or tachycardic, and and it's probably they just before they realized what happened, they saw he had 4 liters and infused. But I agree with the others that you want to try to avoid it. In this case, probably did no harm at all in this patient because the injury was limited. But well handled case though, very well handled.
All right, Dr. Hoffman.
You're muted.
No, I don't have too much to add, except that I agree with Dr. Untracht that ligation is an option in this case. You have other injuries, just ligate and move on. There are too many collaterals there. I am not particularly too worried about this clotting. Depends on the repair, depends if it's too much of a stricture, but I am not, because usually they recanalize. I will use, surprisingly, instead of using continuous sutures, I will use interrupted sutures because that has the chance to better recanalize instead of becoming a permanent stricture. And I also want to, in retrospect, also go back to what Dr. Kasim said about the Penrose drain. This is a two-way portal. If you have a vascular repair, in particular, if I were to leave a drain, it has to be a closed suction drain. So you get the stuff out and you are not allowed for bacteria to go in. But otherwise, really, not too much to add. Congratulations on the case. Nice, very nice case.
Nice. Dr. Dr. Frisbee, any final comments? Anything else?
One of the things that you could think about is if you're going to affect a lateral repair of the vein, I'd start thinking about anticoagulation right then, because the chances of it clotting are pretty much high, very high, and you might as well get a jump on it. As far as the Penrose goes, uh, I don't have any experience with it after about 20 years.
Mhm.
I don't even think they're in the hospitals anymore. But closed suction drainage is, if you need to put a drain, that's what you need, for all the reasons previously stated. It was a very good case. Very nice. Congratulations.
Perfect. Thank you. Dr. Untrak, you have your hand raised?
Yeah, I forgot to mention. So this patient had dysphonia, but no tracheal injury. So that's actually there you go. But still, doesn't matter. I think intubating the patient was the right thing to do. And as Dr. Varone mentioned, if you'd done it over the flexible bronchoscope, you would have seen right away, and still probably would have let the tube in regardless. But there you go. I think it was better to have done the way you did.
Nice. Dr. Veron, you're just cited. So any final comments on the case?
No, I agree with the comments. We talk about the crystalloids. Also the area, when you have subacute emphysema, a pneumothorax kind of explains that, but airway injury needs to be ruled out. So a bronchoscopy would have been ideally before intubation, or if not, at any time, just to rule out. Probably in this patient, if he had it, it was small and the heel on his own. So it was really not an issue, but it was a true save on the overall effort.
Agree. Dr. Kasim, final comments?
Couple of questions. It is not very common for a patient to get upper limb thrombophlebitis and thrombosis. And so, although this was very well done case, beautiful case, I would probably go back and look at this patient's protein S and protein C if he has any predisposition to forming clots. And the second thing is, when I repair venous, especially veins, the big veins such as innominate, popliteal, iliac, I always use an argyle shunt. It doesn't take me very long to slip in an argyle shunt with two clamps on both sides. The flow is maintained while I'm doing the repair, and I pull the shunt out and finish my repair. It works for me very well. I've never had upper limb thrombosis like this patient had. So those are the thoughts that went through my mind.
Interesting. Thank you. And just so before we finalize the meeting, the Dr. Nakar just wrote in the chat, great case and great save. Congratulations. I would just add to try to evaluate the thoracic duct when you have an injury near the left subclavian / jugular confluence. So it's interesting. You might end up with an injury to the duct and sometimes some pleural effusion, and that is very difficult to treat and to stop it. All right. Dr. Eduarda, thank you very much for your presentation. Was very well done and also very well documented, which is great for our discussions here to have the videos, the pictures, X-rays, CT scans, post-op pictures, and it's very, very interesting to have them all. So Mr. Kevin Miller, he wrote on the chat previously about the CME. So anyone who's interested in get the CME for this meeting will be able to click on the link, and you'll be directed to get your CME. So feel free to use it. And I hope to see you all in our next meeting next Monday for another very interesting discussion. For the panelists, thank you very much for all your comments. As always, you were they were very well done and very helpful for everyone who's on the meeting for sure. Thank you very much. See you all next week.
Thank you, Carlos.
Thank you very much.
Oh, you're welcome. You're welcome. That's good.